All right, a ventricular couplet is two PVCs with no intervening pause. So a run of ventricular tachycardia is a term for three or more PVCs in a row, also referred to bursts or salvos. Bigeminy is a pattern that occurs when complexes become so frequent that they begin to alternate with normal complexes, generating a normal PVC or normal PVC pattern. Ventricular trigeminy is a pattern of every third beat being a PVC. Normal, normal, PVC. Most often originate from ischemia in the ventricular tissue, generally considered more serious than premature atrial or junctional complexes, because again, your last line of defense in the ventricles, and it's your main pumping method of the heart. Occasional PVCs are common and usually don't require treatment in otherwise healthy patients. So there is a principal hazard of PVCs that the R wave of the PVC may occur during the T wave of a preceding complex. And this would be called an R on T phenomenon that can lead to VFib. This is what can happen with Komodo mortis. I think it's Komodo mortis. Whenever, if you could like 5-finger death punch, you punch somebody in the heart at just the right time. You got to get very lucky to do it, but you could hit that R on T phenomenon, throw them in the VFib, end up killing the person. PVCs can occur in patients with heart disease, and they require close monitoring and search for underlying cause. Then we have our idioventricular rhythm. So if we look at this, what do we see? Very simple and slow wave. We don't see any P waves at all. No P waves. What does that tell us? Ventricular. Idioventricular rhythm occurs when the SA and AV nodes fail and the ventricles must pace the heart. Usually regular with a little variation between the R and R intervals. No P waves, so no PRI. Rate of 20 to 40 beats per minute, usually within a regular or little variation between R to R intervals. The QRS complex is more than 0.12 seconds, and agonal rhythms, patterns created when the ventricular rate slows to less than 20 beats, may or may not result in a palpable pulse. Treatment improving by the cardiac output is an increasing rate and, if possible, treating the underlying cause. If there is a pulse, then we're going to treat the rhythm in accordance with bradycardia algorithm. But if there is no pulse, then the patient is in cardiac arrest. PEA activity, we're going to throw epi and electricity at him. Accelerated idioventricular rhythm. This rhythm occurs when an idioventricular rhythm exceeds 40 beats per minute, but remains less than 100 beats per minute, not to be confused by accelerated junctional rhythm, which would be 60 to 100. This is 40 to 100. Accelerated idioventricular rhythm. P waves are absent, so there is no PR interval. The QRS complex is 0.12 seconds, 120 milliseconds or more. May be observed during the first 12 hours of the acute myocardial infarction or after reperfusion therapy. Do not suppress these rhythms with ventricular antidysrhythmic agents. Ventricular tachycardia. Ventricular rhythm that is exceeding 100 beats per minute. We are having V-tach. The rhythm is regular with no variations between the RR interval. P waves are absent. So the PRI does not exist. The QRS complex is 0.12 seconds, 120 milliseconds or more. This is considered a wide QRS tachycardia. QRS complexes usually have uniform tops and bottoms and are monomorphic. Yes, they're all monomorphic, all the same. Occasionally, the QRS complex will vary in height, allowing a polymorphic pattern or for ventricular tachycardia. The wide irregular tachycardia present in about 25% of hospital cardiac arrests involving VT. The most common is torsades de pointe, which is what this looks like. If the patient is stable, Emergency care should focus on the treatment with antidysrhythmia medications, one being max sulfate. If the patient is unstable, electrical therapy using synchronized cardioversion may be necessary. If they're going into VFib, the rhythm in which the entire heart is fibrillating without discernible pattern. Occurrences may happen when the cell becomes depolarized independently rather than from the SA node impulse. So this is happening all around the heart, not just in AFib where it's just the top and the ventricles can catch it. Now the whole heart is basically having a rate. No P's, no PR intervals, no QRS complexes. Looks like even less defined than that. This is VFib. When fibrillatory waves are greater than 3 millimeters in amplitude, the dysrhythmia is called coarse VFib. When the defibrillatory waves are less than 3 millimeters in amplitude, it's called fine VF. That looks more like asystole, but sure, we'll call it fine VF. Defibrillation is effective for VFib, pulseless VTAC, and delivers a current that is so powerful it will depolarize all of the heart's components and muscle cells. Automated external defibrillator, the AED, and then we have manual defibrillators. AEDs and manual defibrillators deliver energy in waveforms. Monophasic waveforms deliver energy to the heart from the defibrillation pad to the other in a single direction. Biphasic waveforms are energy travel through the heart from one defibrillation pad to the other and then reverse direction, flowing back through the heart into another pad. So 2-round burst, it goes like a boomerang, zip zap. To properly perform manual defibrillations, we're going to refer to skill drill 17.4. I don't have that in the book, but you're going to stick the pads on here and here. If it's a baby, it's going to go here and on the back. Wearable cardioverter defibrillators, designed for patients at risk of sudden cardiac death, but who are not immediate candidates for therapy with an implantable cardioverter defibrillator. Examples would be the life vest houses, non-adhesive sensing electrodes, and separate defibrillation electrodes. Continuous reads and records the patient's ECG and up to 5 biphasic energy shocks can be delivered for a single event. Asystole, this is our flat line, the only true arrhythmia. I guess it's smoother than fine VFib, so that's why it's not VFib. The only true arrhythmia in the entire heart that is no longer contracting and shows no evidence of organized activity. The complete absence of ventricular electrical activity. P waves may be occasionally seen, but with no QRS complexes or T waves, called the P wave asystole, ventricular asystole, or ventricular standstill. A flat line on an ECG monitor may or may not consider asystole. Asystole is considered a non-shockable cardiac rhythm. We are going to throw epi at this. Pulseless electrical activity, also throw epi at it. Same thing as asystole for the most part. An organized cardiac rhythm that is not accompanied by a detectable pulse, and the mechanical ventricular activity is too weak to produce a palpable pulse. As in the case of cardiogenic or hypovolemic shock, cardiac tamponade, massive pulmonary embolism, electrolyte imbalances, and disturbances including hyperkalemia and renal failure. You could also get it from drug overdose. Key to treatment is identifying the cause. PEA is a non-shockable cardiac arrest rhythm. How are we going to manage it? Most patients with cardiac arrest have evidence of prior heart disease. They can also occur from electrocution, drowning, trauma, drug overdose, asthma, or anaphylaxis. Possibly no warning before the event. Cardiac arrest management requires an orderly, systematic approach that is repeated in a team setting. So we're going to bring the following devices whenever we approach the scene. We got a defibrillator, oxygen cylinder, IV equipment, drug box, and airway management equipment and intubation kits. And we're going to bring our auto pulse because that takes a lot of effort and we can't do it as good as the auto pulse. The goal of the emergency medical care for the patient in cardiac arrest is to include return of spontaneous circulation, or ROSC, and the preservation of a neurological function. So we're going to begin emergency medical care immediately upon discovering pulselessness. Withholding CPR is considered appropriate when we attempt to perform CPR that would place a rescuer at risk. There is obvious clinical signs of irreversible death and treatment form in indicating that resuscitation is not desired or a valid. Do not attempt to resuscitate if the order is presented to rescuers. Let's see if we even need this. Do we need this? Management of adult cardiac arrest. Obviously, don't interrupt. 100 to 120, depth of 2 inches. Okay, for possible cardiac arrest rhythms, we have pulseless VT, pulseless VFib, asystole, and PEA. Any of these would cause a person to lose consciousness and responsiveness. So key point to remember, if defibrillation is indicated, then the provider is giving chest compression should continue while a second rescue charges the defibrillator. Then we're going to pause CPR, clear the patient, deliver shock. Resume chest compressions immediately without a pause for a rhythm or pulse check. After 2 minutes or 5 cycles of CPR, pause resuscitation efforts and check on the rhythm of the monitor. If the rhythm is other than VFib or VTAC appears, then we're going to identify a new rhythm and check for a pulse. If there is no pulse, then move down the algorithm to the asystole PEA pathway and immediately resume CPR. If there is a pulse, then we're going to move to the appropriate algorithm of the new rhythm. VFib or VTAC, that's shockable, and we're going to do CPR while we're waiting for the pads to charge. Make sure you rotate out, don't get tired. Use normal saline to attempt to establish vascular access. If you're unable to get IV access, we're going to move to the intraosseous access with the bone gun, using the adult's intraosseous system. Vascular access should be achieved without interruptions, without interrupting chest compressions. As soon as IV or IO access is established, administer epinephrine of 1 milligram, 1 in 10,000 is administered IV or IO and repeated every 3 to 5 minutes until a pulse returns. Whenever you give medications through peripheral IV during CPR, follow immediately with a 20 milliliter flush of normal saline IV and elevate the extremity of 1 to 2 minutes to facilitate delivery of medication to the central circulation. Several options are available for airway management. We have a bag valve mask that can be used throughout the resuscitation effort. For adults in cardiac arrest without advanced airway, use a 30-to-2 compression ventilation ratio. Ventilate with just enough volume to produce visible chest rise and deliver a breath for about 1 second. So don't do it too fast because you might make them vomit. And we want to observe capno. VFib or pulseless VTAC that persists or returns after 1 or more shock is called refractory VFib or VTAC. An antidysrhythmic such as amiodarone may be considered. We could also do lidocaine if not amiodarone. And how much do we give? We'll talk about that in pharmacology. Or now. Let's talk about it now. So I'll talk about it now. Okay, so what could cause cardiac arrest? We got our H's and our T's. We got hypovolemia, hypermagnesemia, hyperkalemia, all the different electrolyte imbalances basically. We got tension pneumothorax. So that's whenever the chest is tight, full of air or fluid. No, cardiac tamponade is full of fluid. They'll have jugular venous distension from this too because of all that fluid. So we want to immediately transport for pericardiocentesis. It could be toxis, thrombosis, whether it's coronary or MI, pulmonary. And yeah, hypovolemia, hypoxemia, flat veins. So volume replacement, we
If we have blood, that'd be awesome. Probably don't.
Special circumstances in cardiac arrest. Cardiac arrest that requires a paramedic to adjust treatments and procedures include morbid obesity. Definitely. I remember